Welcome to this explainer. Today, we're cracking open the clinical playbook for positive and expiratory pressure, or PEEP.
So how exactly do you keep a collapsing lung open when supplemental oxygen just isn't cutting it?
The answer is PEEP. It holds a constant baseline airway pressure, literally preventing alveoli from collapsing during exhalation.
Now don't confuse it with CPAP. CPAP is for spontaneous breathers, whereas PEEP pairs with mechanical ventilation modes.
Think of blowing up a balloon. It's toughest at the start, right? PEEP keeps the lungs slightly inflated.
This physiological hack reinflates alveoli, boosts functional residual capacity, and vastly drops the patient's overall work of breathing. When do we use this? The absolute top indication is refractory hypoxemia, where high oxygen just isn't enough.
We also use it for stiff lungs, or to combat auto-PEEP by effectively raising the baseline pressure.
The clinical workflow usually kicks off with an initial PEEP setting of exactly 5 centimeters of water.
From there, we hunt for the optimal PEEP. It's a total high-wire act, balancing oxygenation against major complications.
Check this out. Increasing pressure boosts oxygenation and compliance at first, but then it just completely drops off.
If we push past that sweet spot, things go south fast. What happens if pressure gets too high? PEEP raises mean airway pressure, which can actually decrease venous return, totally tanking cardiac output and blood pressure.
That cardiac drop directly starves your organs, noticeably slashing hepatic blood flow and severely decreasing kidney perfusion.
In patients with normal lung compliance, PEEP can even block venous return from the head, raising intracranial pressure.
Here's the danger zone. PEEP levels pushed past 10 centimeters of water absolutely skyrocket the risk of barotrauma.
That high pressure literally ruptures alveoli, causing severe lung injuries like a pneumothorax or even a pneumomediastinum.
Once your patient stabilizes, you need an exit strategy, weaning from PEEP to man's extreme caution and constant monitoring.
First rule, the inspired oxygen fraction, or FiO2, must be lowered to non-toxic levels of 40 to 50%.
The whole weaning workflow is step by step. You lower the oxygen first, then you decrease PEEP in tiny increments. During this, you've got to make absolutely sure the patient's PaO2 stays above 60 or SpO2 above 90%.
Which leaves us asking, how do we perfectly balance aggressive mechanical force against incredibly delicate human physiology?